is an adult infectious disease physician and epidemiologist who currently works as a medical consultant for the Southeastern National Tuberculosis Center and also has her own public health consulting practice focused on TB, HIV, maternal and child health, among other things. Dr. Haley received her medical training from Vanderbilt University, including specialization in internal medicine and infectious disease, and a master's of public health degree. She has a long history working in the TB field, including serving as 5 years as medical director of the Tuberculosis Elimination Program at the Tennessee Department of Health, 3 years as the director of tuberculosis research for TDOH, and 6 years as the principal investigator for the Tennessee site of the TB Epidemiology Studies Consortium. Although she no longer provides direct clinical care to patients living with HIV, Dr. Haley has remained active in the HIV field by providing training and education and developing and evaluating programs to engage patients in HIV prevention and care and prevent further transmission within their communities. Dr. Haley is currently an adjunct professor in medicine in both the Division of Infectious Disease and Global Medicine and at the University of Florida, and in the Division of Infectious Disease in the Department of Medicine at Vanderbilt University. She enjoys collaborating closely with the Centers for Disease Control and Prevention and academic and public health partners across the U.S. to improve the clinical management of patients with latent tuberculosis infection and active tuberculosis disease, including those who are co-infected with HIV. So thank you for joining us today, Dr. Haley.
Good morning. Can you hear me?
Yes, ma'am.
Okay, good. Good morning, everyone. Thank you so much for joining us so early at the beginning of your work week. I hope that this will be helpful for you, and again, be glad to answer questions at the end or also via email later. So they asked me to speak today about tuberculosis and HIV focused on healthcare providers. Here we go. And so my objectives are going to talk about the increased risk for developing tuberculosis among HIV-infected persons, to test for the presence of tuberculosis infection in HIV-infected persons, to help you be able to formulate a plan for treating infection or active tuberculosis disease in those who have HIV, and also to recognize and manage complications of tuberculosis treatment in HIV-infected persons. So I want to talk to you first about the HIV and tuberculosis pandemic, and this is basically where there are high levels of both of these infections out there, and they interact with each other in ways that the effects of both diseases are worsened. And I want to focus mostly on tuberculosis in these first few slides, and tell you that this is important because of the magnitude of the tuberculosis epidemic. It's estimated that one person dies of tuberculosis every 20 seconds. That's 3 every minute, and the equivalent of a jumbo jet full of people crashing into the ocean every hour. And I know that sounds incredibly morbid, but it is a tremendous epidemic worldwide, and that's alarming to us all because tuberculosis is both preventable and curable. The WHO puts together a report every year estimating the impact of global tuberculosis and measuring the progress that's made. And it's estimated that about 9.6 million people developed tuberculosis in 2014, and the global estimates are typically about 1.5 to 2 years behind just because of the time and effort it takes to collect all of the data. So that's why 2014 are the latest estimates that we have. As you can see, more men than women are affected. But what's of great concern is that over 1 million children developed tuberculosis in the last year that we have data. Of additional concern, about 12% of persons who are newly diagnosed with HIV also developed active tuberculosis. There's about 1 million too. And in 2014, TB killed about 1.5 million people, and many of those were HIV infected. It's also unfortunate and very concerning that only about 2/3 of new tuberculosis cases are actually detected and reported. And that means that about 37% of new cases, or somewhere around 3 million individuals, have active tuberculosis, but it goes undiagnosed. And that means that those individuals don't get the benefit of treatment and therefore have high mortality and many, many die. But also that means that transmission continues in the community, and that leads to the epidemic continuing, very high rate of affecting the population. Tuberculosis is a leading killer of HIV-infected persons, and as you know, it's considered an opportunistic infection that occurs because of the impact of HIV on the immune system. And it's also considered an AIDS-defining condition. But what's important to note is that tuberculosis, unlike many opportunistic infections that occur primarily as immunity wanes, tuberculosis can occur at any CD4 count, and it's not necessary that patients have AIDS to develop active tuberculosis. I wanted to show you this map of the world showing the estimated tuberculosis incidence. And as you can see, the areas in the darker green are the areas that are most heavily affected. And that includes sub-Saharan Africa, Southeast Asia, India and China, as well as Eastern Europe and South America. I mean, it's a global disease for sure. It's less common in developed countries, but it certainly occurs all over the world. And this next slide shows you something that probably won't surprise you, and that's when you look at the HIV prevalence among tuberculosis cases, it's really occurring in a very similar location, sub-Saharan Africa, India, and Southeast Asia, among other parts of the world. I wanted to focus now on reported tuberculosis cases in the United States, and I'm happy to say that we've made great progress and that we have an excellent surveillance system such that most of our cases are detected and reported, unlike the one-third that are not detected globally. And as you can see from this, this is the number of cases over the last more than 20 years. And you can see that there's some initial progress. Let me see if I can get this pointer to work. Let's see. I'm not sure if you can see my pointer, but you can see initially there was a sharp decrease and then a leveling off. And then we have what we consider a resurgence of tuberculosis, where case rates went back up, and we had a high burden of tuberculosis occurring at great cost of both money, resources, and also lives lost, as well as persons that experienced great morbidity. Taryn, I'm seeing a note that connection was lost.
It's looking like you're still there. We still see you on there.
Can you all see me now still?
I see you still listed there as a presenter. See if you can advance the slide and
okay,
if it communicates with you.
If you can still hear me, I'm just going to continue on then. Okay, so in 2014, we've made substantial progress. You could see after our resurgence, there was a steady decline. And in 2014, we reported just a little over 9,000 TB cases with a case rate of 3 per 100,000 population. So that's still a pretty significant burden of cases occurring in the United States. And I want to talk just a bit about this resurgence and show that between the late 1980s and the early 1990s, we did have that resurgence. And HIV, which was really emerging, being recognized and spreading quite rapidly, was really recognized as a significant underlying factor for a resurgence of tuberculosis cases. In addition, immigration from countries where tuberculosis was common that I showed you in the two global maps, that had a huge impact on our resurgence of tuberculosis, as well as transmission of tuberculosis in congregate settings and the development of multi-drug resistant TB that we were trying to get our arms around, recognizing and treating and trying to take care of those people. But a significant factor was that funding was cut, and that had a huge impact on our ability to manage all these issues that were occurring and impacting the increase in tuberculosis case rates. And so I'm happy to say, as you saw from the slide, progress has been made. But what we're seeing this year is concerned. CDC released just on World TB Day last month that progress towards tuberculosis elimination has stopped. And that's a really significant statement. But what's concerning is that in 2015, for the first time, the United States reported an increased number of cases for the first time in 23 years. It was just about 9,563 cases, and while this is provisional data, they'll be finalized in probably in the next month or so, that's still very concerning. And again, our early detection is good because it helps us be aware that this is a problem that we can address, and hopefully that will be done. But unfortunately, funding remains quite low for tuberculosis, and so this is something that will really need increased political buy-in. But in our country, I also wanted to highlight where TB is occurring so you can be familiar with risk factors and being aware of patients that might come to your clinic who would be at risk for tuberculosis. And while TB can affect individuals of really any race and any ethnicity, any background, any social strata, it is really much more common among minorities. As you can see here, the case rates are highest among Asians, which is the red line, followed by Native Hawaiian and Pacific Islanders, Blacks or African Americans, and Hispanic and Latinos. And all of those racial ethnic groups have much higher case rates of tuberculosis compared to the white population. And of more significant concern is that immigration continues to be a major driving factor, probably the major driving factor in the U.S. TB epidemic. And so when you see patients that come to your clinic that are born overseas, especially in high-incidence countries, as I showed you on the initial map, those are individuals you need to be thinking about being at risk for active tuberculosis or tuberculosis infection. And as you can see here, the blue line represents the U.S.-born population. And you can see that those rates are coming down somewhat in line with the graph that I showed you earlier about TB case rates, whereas the green bars represent the foreign-born. And you can see much less progress is being made, such that in our next slide, when you look at the percentage of U.S. TB cases occurring in the United States, almost 70% of our cases are occurring among foreign-born individuals. And so, again, that is the major group of which we need to be focusing our TB elimination efforts. I do want to talk briefly about, or not briefly, but show you the estimated HIV co-infection among TB cases here. And as you can see, there's been very good progress, where both for all ages, which is shown in green, and the age group of 25 to 44-year-olds, where HIV incidence is the highest, HIV prevalence is the highest, you can see that much progress has been made, but it is somewhat leveling off over the last 10 years. And among all ages, about 5 to 6% of TB cases have HIV. That's a little bit higher in the age group of 25 to 44. So TB and HIV continues to be a big problem in the United States, both because of the number of individuals affected, but also because of the severity of illness. And I'm going to switch now to talk more about tuberculosis and help you understand more about this infection and how it impacts HIV. So when we talk about mycobacterium tuberculosis, it's an airborne disease. It can also be spread other ways, but the majority of disease is spread through the air, and it's caused by a bacterium, mycobacterium tuberculosis. And I wanted to note that this is really a complex of multiple organisms, multiple species. And so I'll probably just call it tuberculosis during most of my talk, but I wanted you to be aware that there's multiple species, and it can be spread through unpasteurized milk, and that's primarily in bovis, but also through direct inoculation from an infected wound and other means. But again, airborne transmission is the predominant route, and I'm going to focus on that for most of the talk. So it's spread via airborne particles called droplet nuclei. And as you can see from this picture, it's expelled when a person who has infectious tuberculosis in the lungs coughs, sneezes, shouts, or sings. And there needs to be a forceful cough to be able to expel the germs into the air. And typically, it's transmitted through droplet nuclei of a certain size. They really need to be 5 micrometers or smaller. And those droplet nuclei typically contain anywhere from 1 to 10 tubercle bacilli. And while one bacilli can cause disease, usually infection requires a bit more than that to cause human infection. But once these are inhaled, the bacilli can become lodged in the distal airways, typically in the subpleural foci and the lower lobes. And pathogenesis, we do have a very good immune response to tuberculosis infection, but it's insufficient to completely cure it in many people. So pulmonary macrophages ingest the tubercle bacilli, and the bacilli can replicate within the macrophage. Some are killed, but some continue to replicate. And eventually, when the replication exceeds the cell size, they burst from the cell and can be spread through the bloodstream and lymphatics. A period of brief dissemination through the bloodstream occurs, and that really stimulates a host immune response. It's activated so that it can limit the spread of infection And in most cases, it's able to do that, to wall it off and prevent it from becoming active tuberculosis disease. And this will involve granuloma formation around the bacilli and intracellular killing, as well as T-cell-mediated cytokine responses. So it's a good T-cell-based immune response. And about 2 to 8 weeks after the initial infection, the immune response can actually be detected by the tuberculin skin test, the TST, or through a blood test that's been developed for this purpose called the interferon gamma release assays. There's actually several different assays that we'll talk about later. But in the incidents where the immune system is not able to contain the tubercle bacilli, they continue to multiply, and it can occur in sites that had been infected during the initial hematogenous spread. It can really be anywhere, typically the lungs, but also kidney, brain, bone, anywhere, the GI tract, the eye. So typically the initial infection, if it occurs soon after infection, it's called primary TB disease. And we'll talk more about that in a minute. And this is just, as you can tell, a section of the lung, and you can see the dark white is, if I can make this pointer, I'm pretty sure that's obvious to you, but there's a calcified granuloma in this tissue specimen. And what it looks like on X-ray is here on the periphery on the right, you can see a dark white opacity, and that is a granuloma that's healed. And so now I want you to think about who should we test. We've talked about the epidemiology. We've talked about when TB is common. And so I really want you to think about 2 categories of individuals who might come to your clinic that need to be evaluated. And certainly there's exposure risk, and those are individuals who have risk for recent tuberculosis infections, and also a group of individuals who, once they're infected, have a high risk of going on from that initial infection to full-blown active tuberculosis. When we talk about exposure, close contact are individuals who shared space with a person who's, as we mentioned, able to cough and expel the organisms into the air. And typically the risk is highest within the first 2 years after exposure. And lifetime risk for an individual without HIV is 10%, 8 to 10% in their lifetime. And about half of that risk occurs in the first 2 years after exposure and infection. As I mentioned before, individuals who've immigrated from areas of the world with high rates of tuberculosis are also at higher risk of exposure and infection. And also in the United States and other places, residents and employees of high-risk congregate settings, which typically don't have very good infection control and have a lot of crowding of individuals who might be high risk together in a setting where TB could spread, then they might have as good access to health care. And that would be correctional facilities and in homeless shelters. And worldwide, healthcare facilities is a significant risk factor for tuberculosis. And I'll just say in the United States, we've done a much, much better job with infection control, and the risk of spread in healthcare facilities is certainly lower. But because individuals who are sick with pulmonary disease can come to healthcare facilities, and because TB is somewhat less common than it used to be, it can sometimes be missed, and there is risk of spread in healthcare facilities even today when we know what to look for and we have good measures to prevent it. Additionally, we talk about individuals who get infected and then they'd be more likely to spread from latent infection to active TB. And those are, again, the recent converters within the first 2 years after infection. Also, as HIV-infected persons, because of their immune deficiency, they're at significant risk of getting infected and also rapidly progressing from infection to active TB disease. Similarly, young children have very immature immune systems, and so if a young child has a positive skin test or IGRA result, then they could be presumed to have been recently infected by virtue of their age, and they're also at risk of going on to develop active TB disease very quickly, and also developing the significant forms of TB like TB in the CNS system and also disseminated disease. Individuals who've had a history of prior untreated TB or fibrotic lesions on the chest X-ray are at a very high risk of those lesions breaking down, as they do contain some live organisms that might be slowly replicating. And so when you see a patient from overseas who may have said, I had TB when I was younger, but they continue to have these old healed lesions on their X-ray, those individuals are still at high risk for breaking down and need to be evaluated and managed. And I'll just tell you that active tuberculosis, about 50% of individuals overseas who don't get detected will heal spontaneously for a while. But because they didn't get treatment, they do have that risk of breaking down again in the future, and this is the group that I'm talking about. Injection drug users are at higher risk of progression to active TB because of their increased risk of having HIV, their increased risk of having poor health care, malnutrition, poor access to health, and also sometimes silica is mixed in with some of the agents that they ingest, and that can also increase the risk of active TB. And then we're finding now that as the TNF-alpha antagonists, Humira and Enbrel and all these other drugs, as they're being used more and more for rheumatologic and other immune-mediated diseases, we're finding that active tuberculosis is occurring among that group at a pretty high frequency, and again occurring in really high, unusual, with unusual clinical presentations. And so it's important to think of patients taking immunosuppression, especially TNF-alpha antagonists, as being at high risk for tuberculosis. Other conditions, clinical conditions, HIV, low body weight, being malnourished, silicosis, because of the impact of the silica dust bogging down the pulmonary macrophages, which are an important line of defense in the lung against TB. We're finding that diabetes is a significant risk factor with maybe 3 times increased risk, but also increased risk of bad outcomes and active progression. And so this is, as you know, the epidemic of diabetes is substantially increasing throughout the United States. This is a big group for us to be focusing on. Chronic renal failure, gastrectomy, jejunal ileal bypasses, solid organ transplants, and head and neck cancers or other clinical conditions that are associated with increased risk of TB in individuals that are infected with the organism. I want to make sure that it's clear the difference in latent tuberculosis infection and active TB disease. And latent infection is basically a much slower subclinical replication of just a few organisms, whereas in active tuberculosis, there are usually a much higher burden of organisms. They're actively replicating. They're causing clinical disease, either in the lung or other sites. But while we tell patients often that latent infection is when the germs are asleep in their body, and that's really an oversimplification, because if they were truly asleep, we wouldn't have patients waking up and developing clinical tuberculosis. It's really a slow replication that's ongoing, and as some are waking up, the immune response is responding to those and keeping those from progressing. So it's really more of a continuum and more of a slow replication. But it's happening at such a low level that they're not infectious, and they cannot spread the infection. So latent infection is not contagious, whereas patients with infectious tuberculosis disease, when it involves the lung, are contagious. Typically, we can diagnose latent infection with either a skin test or an IGRA, and we'll talk a little more about that. But if either of those tests are positive, that's indication that there is an immune response to the antigens in the body, and we're measuring the immune response, and that shows us that there is infection present. By definition, because there's no clinical disease with latent infection, the chest X-ray is negative, and there are no symptoms of active TB disease. But these individuals do have the organisms in their body, and they have the potential to have increased replication and to reactivate or cause more significant disease in the future. And so we do need to diagnose infection, and we do need to address that through preventing it with treatment. Tuberculosis disease, as I mentioned, lung disease is the most common form, but it also can occur in absolutely any site in the body, as well as miliary or disseminated disease with multiple sites at once. The typical constitutional symptoms are fever, weight loss, night sweats, cough, or hemoptysis. And as you can see on these x-rays, the one on the left shows pulmonary disease, where you've got a typical right upper lobe involvement. This actually involves multiple lobes. There may be a cavity in the very upper aspect of that right upper lobe, but it also involves the left side. In the second picture, you can see that there's sort of a diffuse covering of little millet seed-sized nodules, and that's called miliary TB. It's a very classic presentation. It's not the only thing that can cause something like this, but it's the most classic. As I mentioned, extrapulmonary can occur in any site, but it's not typically infectious unless the person also has pulmonary disease at the same time, which does happen frequently. And if TB is involving either the oral cavity or the larynx, where it could be aerosolized into the appropriate size of the droplet nuclei that could then be inhaled by another person. But extrapulmonary TB can also be spread, though not very often, if you have an open site, such as a wound that's not detected until surgery and there's high-pressure irrigation occurring. It can be aerosolized. And we even have patients who have, unfortunately, during autopsies, where the morticians are preparing the body and might again have that high-volume irrigation, and it aerosolizes, or the saw that can aerosolize particles that can be inhaled by the individual conducting those procedures. So it can be spread as long as those particles get aerosolized. And so I want to tell you an important point, and that is that even when extrapulmonary disease is present and you don't think the patient has pulmonary symptoms, we always obtain sputum smear and culture of for mycobacteria to make sure that there's no pulmonary disease, because that changes our management, and it means that individuals need to be isolated, and we'll need to do an investigation to look for people who might have been exposed that we can prevent TB in. So I want to talk now about tuberculosis, specifically in individuals with HIV co-infection, because this has really substantially increases the problem in both diseases. I'll talk first about the effect of HIV on tuberculosis disease. As we mentioned, HIV increases the susceptibility that a person with will get infected if they're exposed to the tuberculosis organisms. And they also have an increased progression from latent infection to active disease. And rather than 10% per lifetime, individuals who have HIV can have a 10% risk per year of developing active tuberculosis once they're infected. And as I mentioned, disease can occur at any CD4 T lymphocyte cell count. And the risk does increase as a person becomes progressively immunodeficient, and the risk may decrease again as they get better. But the risk remains high in individuals with HIV, regardless of whether or not they're on treatment and they've got a relatively well-functioning immune system. Individuals with HIV also can have unusual clinical presentations of TB disease, which can make it harder to diagnose and harder to manage. And they have higher morbidity and mortality, as you can imagine. There's also an increased risk of reinfection even after they've taken preventive therapy. And that's much more of a problem overseas, where tuberculosis transmission is much more prevalent, but it does occur in high-risk settings in the United States as well. And we talked about pathogenesis before, but I wanted to show you this and how it's a little bit different in HIV. I kind of always thought this picture of the mother and child was slightly creepy, but it shows that especially children who are vulnerable, but also HIV-infected individuals get exposed from those with active tuberculosis, and they are more likely to get infected. And within 6 to 8 weeks, the immune response has occurred such that we, in some individuals with HIV, can detect it with a skin test or IGRA. And in most non-HIV-infected individuals, we can detect infection between 6 to 10 weeks. Most individuals heal spontaneously. If they immediately develop TB right after infection, we call that, again, primary tuberculosis. But if they spontaneously heal, they can develop latent infection where they are not sick with a normal chest X-ray and not infectious. And as I mentioned, some of those will progress within the first 2 years and reactivate to active TB disease, and some will develop TB much later in the life with reactive tuberculosis. But if you look down at the bottom with the blue circle, you can see that those with the HIV infection, again, the risk going from latent to active TB is much, much greater, 10% per year. And I also wanted to compare HIV negative and HIV positive, and noting that the estimated annual risk of TB among HIV-infected patients is 3 to 12 times the general population, whereas in HIV-negative patients, about 30% that are exposed get infected. HIV-positive, it's about 70%. And among individuals that go on to develop active TB, about 30% of those that were infected, 5% of those 30% that are HIV-negative develop primary TB disease, whereas HIV-positive, you get HIV much more quickly, and about 40% of those who are infected will develop primary disease very soon after
within weeks to months of being exposed. And so again, if someone's a contact to HIV, someone has HIV and is a contact to an active case, those individuals need to be evaluated very quickly because they can go on, even while you're investigating and evaluating them, they can actually go on and develop active TB. And again, the rate of reactivation down the road is also much higher, 5% after the first 2 years for HIV-negative individuals, whereas it's 45% reactivation risk among HIV individuals. I wanted to talk about antiretroviral therapy because it's actually a very, very important way to control active tuberculosis. It's recommended, as you know, for all individuals living with HIV, irrespective of their CD4 cell count. And that's a U.S. recommendation and a worldwide recommendation, although overseas there's limited resources and it may not be as feasible there. They're working on it. But what's important is that antiretroviral therapy, because it improves the immune response, does reduce the risk of TB disease among HIV-infected individuals by 2/3, and that's a substantial benefit. And so what you're already doing to identify individuals with HIV and get them on antiretroviral therapy is very effective for those who may have TB infection to also prevent active disease in those people. And the lower rates of TB disease that are reported on patients receiving ART is largely explained by reduced progression from infection to disease, not as much by reducing the actual transmission. But even though it's very beneficial and prevents TB in many people, I want to reiterate that HIV-infected persons do remain at higher risk of TB disease than the general population, even at high CD4 cell counts and being on antiretroviral therapy. And for that reason, we recommend that all tuberculosis patients need to be tested for HIV so that we can provide them benefit of medical care and antiretroviral therapy to improve their HIV disease. And we also recommend patients who have latent infection to be tested for HIV because, again, knowing someone with infection has HIV helps you to recognize those individuals are a very high priority for preventive therapy so that they don't develop active TB in the future, as well as their benefit of getting ART for their HIV disease. But I think it's important to note that it's a two-way interaction between TB and HIV, and TB has a substantial impact on HIV as well. TB has a significant impact on HIV by increasing viremia and increasing progression of HIV disease, progression to AIDS, and risk of death. It also contributes to a high morbidity and a high rate of hospitalization, which is very costly, and it occurs both in low and high incidence countries. And mortality among these individuals is very high, and so it's important, again, that we recognize individuals early, right after TB infection, and also early in HIV disease. But it's been shown that if we can find and treat those who have latent infection and HIV, that we can decrease their risk by about 2/3, as I mentioned, and it also improves the risk of death. And prevention by screening and appropriately treating is considered a key component of HIV care, and both ART and treatment of LTDI had an A2 recommendation in the guidelines for opportunistic infections in HIV-infected adults and adolescents. I've put the link here on this, and I've included other references throughout this talk that I find very helpful. And as you know, these guidelines are updated very frequently for HIV, which is incredible. Unfortunately, in the TB world, our guidelines are not revised very often. We just seem to have more problems getting them through clearance. The new TB guidelines will be published soon, we hope, for both TB and latent TB infection. But in the meantime, I would just say continue to use your guidelines and rely on TB experts when you're managing patients. And down in the left corner, you'll see there's an HIV and TB document, a little pocket card that we've included that we've just updated, and I found that to be an excellent resource for managing patients. So I just wanted to bring that to your attention. So let's talk a little bit about prevention through treatment. And I just want to reiterate again the difference in latent infection and active TB disease. When the person is infected but not sick with active disease, again, they have very small amounts of TB bacteria that are replicating. and compared to active TB where there's large amounts. We consider latent TB paucibacillary, and it cannot be spread to others. They are not infection. Individuals should not be sick, but again, without preventive therapy, they can become sick in the future, and so that's why we want to identify them. And we can diagnose them by the skin test or the blood test, the IGRAs. There's two. We'll talk about those. And they show that you have tuberculosis infection. The chest X-ray needs to be normal with no evidence of active TB, and sputum smears and cultures would be by definition negative. And they do require treatment so that they don't develop active TB, especially in patients with HIV. They are not infectious, they do not require isolation, and they don't need to be reported as a case. And so I want to now talk about the diagnosis. And I've mentioned that the skin test and the IGRAs are the way that we diagnose infection. And I want to mention again that there is no gold standard. TB disease is diagnosed by culture, and that's the only way we know for sure that there is infection in the body. But someone with latent infection by definition does not have enough disease to be cultured. So unless we ground them up and did testing of the ground up human tissue, which we don't do for obvious reasons, there's really no gold standard. So we use surrogates, and the surrogates are measuring the immune response to the antigen that's there in the body. We can't detect the antigen, but we can detect the immune response. The tuberculin skin test is one way, and it's been used for over 100 years, and it's tried and true. And again, there's a lot of limitations, and as you all may know, it can be falsely negative in individuals with HIV. However, because we've had it for so long, we've really learned the caveats of when we've learned about its limitations and sort of how to interpret it. The interferon gamma release assays, as I mentioned, there are two types. There's the T-spot TB test, which actually measures the number of cells that release interferon gamma, and the test is read by counting the number of positive cells, and there's a certain cut point over which it's considered positive. On the other hand, quantiferon gold, or quantiferon gold in tube, is a blood test as well, where it's actually measuring the amount of interferon gamma that's released. The T-spot counts cells, and the IGRA, the quantiferon test, count the interferon that's released. So they measure the same thing, they're just measured a little bit differently. And both of these tests are very helpful in differentiating those who are infected from those who are not, but these tests aren't perfect. As I mentioned, you can have false negative reactions, especially in patients with immunodeficiency, so that if you have suspicion or knowledge that an individual has been exposed to someone, it's important to consider that there could still be infection you haven't been able to detect. And this gets actually a little bit tricky, but we are here at the Southeast National TB Center for calling us anytime. We have a hotline, 1-800-4-TB-INFO, and it's on my last slide. So if you don't remember that number, you'll have it on your slide. We can help you with this anytime, and you can also, I'm sure, ask other HIV experts as well. So testing for, the guidelines recommend that testing for LTBI needs to be done at the time of HIV diagnosis for all patients with HIV. In other words, it should be routine. And it doesn't matter what their epidemiologic risks are. And non-HIV populations will identify risks and say, well, if you're foreign-born, or if you're diabetic, or if you are a young child who's been exposed to a high-risk adult, or if you're HIV infected, we then test you. But again, anyone that has HIV needs to be screened for latent infection as well. And in individuals who have a negative skin test or IGRA, if they have an advanced HIV infection with the CD4 count less than 200 cells, and if they have no indications for empiric LTBI treatment, which I'll talk about in just a minute, they need to be retested when they start interretroviral therapy and as their immune system improves and they attain a CD4 count above 200. So we retest individuals who have advanced immunosuppression at the initial test when their CD4 cell count recovers. But annual testing is recommended only for those who are at increased risk of repeated exposure. And as I mentioned, and I showed the slides of those who were exposed, if you have high-risk travel or go back, if for foreign-born individuals who might go back home, for individuals who are incarcerated or in homeless shelters or homeless, substance abusers, those individuals who might be around other high-risk individuals or those who are known to be exposed to active TB disease, they need annual testing, but other groups may not. It's recommended that either the skin test or an FDA-approved interferon gamma release assay can be used for screening HIV-infected adults. There are some advantages to using an ISA. It is considered to have a higher specificity than the skin test because it does not cross-react with the BCG antigen and some atypical microbacteria. And so it's a good test to use, particularly in individuals who are foreign-born and have HIV. But it's also useful because it's a blood test. It can be done in one clinical visit, whereas the skin test needs to be read again 48 to 72 hours later. And some individuals may not come back to get it read. And so in that situation, IGRAs are really preferred. Again, progressive immunodeficiency is associated with decreased sensitivity, but it may be that the interferon gamma release assays may be more reliable in advanced HIV. There's still more studies being done. But it's important that if you have a patient that you think is at high risk, because not only are they HIV, they also use drugs and have been in congregate settings and might have been around others. If you have a high concern for infection, we recommend dual testing. And I'll tell you, dual testing with both the IGRA and the skin test is not recommended for most patients. If you have a patient where you're very concerned, there might be a risk of a false negative, and you think they really might be infected, if you get both tests and either one is positive, in that situation we would consider them infected and go ahead and treat. And again, any HIV-infected person who has a positive skin test or IGRA result should be quickly evaluated to make sure there's no active TB. Those individuals who test positive but have not been found to have any active TB should be treated for latent TB infection. It's an A1 recommendation. And remember, we talked about those individuals who might be treated regardless of their test results. And that would include close contacts who we know have been exposed to a TB case. And those individuals should receive prophylaxis or window therapy regardless of their screening test. So if you know that they're contact to active TB and they have HIV, regardless of what their skin test or IGRA results are, we do go ahead and treat them because we know we can't rely on their diagnostic test. And we know that the risk of progressing to active TB is very significant. HIV-infected individuals who are allergic and have not had recent contact to any individuals do not need to be retested. So again, we're talking about who to treat. These are the guidelines. These are the most recent guidelines. Positive screening test for latent infection, but no active TB and no prior treatment for active TB or LTBI. Those individuals should be treated. Also, close contact with infectious TB patients who have no active TB need to be treated. And for HIV-positive persons, the currently recommended regimen is isoniazid for 9 months, using B6 as well as a vitamin to prevent neuropathy. And it should be given daily, but in certain circumstances it can be given twice a week only by directly of their therapy. But again, daily is the preferred regimen. And in the non-HIV world, we use quite a bit of rifampin, 600 milligrams for 4 months. But in HIV, because rifampin interacts with antiretroviral therapy, this is not used very often. It can only be used in patients not on antiretroviral therapy. And rifabutin can also be used in some individuals who are on concomitant ART if they cannot take INH because of drug resistance or intolerance. I wanted to also mention to you that in the non-HIV TB world, we use quite a bit of a new regimen called 3HP, or isoniazid plus rifapentine. Rifapentine is a long-acting rifamycin that enables once-weekly dosing in combination with isoniazid. So we can use this regimen, giving it once a week for 12 weeks, and it's very effective, but only given by DOT right now. And it's been shown in good randomized controlled trials to be equally effective and low risk for toxicity, and again, in HIV-negative individuals. But it's not recommended for patients with HIV because those individuals, again, may be on antiretroviral therapy, and their drug interactions with rifapentine are the same as with rifampin. Karen, I just want to check that you guys still have an audio connection because I'm seeing the loss of the visual connection.
We can still hear you, Dr. Haley.
Okay. I'm going to just try to get my slide print out and talk quickly about, let's see, where am I while you're pulling that out? All right, I'm moving on to my paper. And so we do not use 3-HP in most individuals with HIV. So we talked about the IGRA advantages already in the dual testing. We talked about treatment. We talked about 3-HP. I want to talk now a little bit about prevention. Prevention is the most important thing that we can do, and so patients who have HIV infection or travel overseas need to be counseled about their risk of infection and advised they be screened quickly upon their return for testing. And again, individuals in high-risk settings need to be screened, correctional facilities and homeless, but they otherwise don't need any other prevention measures. So I want to move now and talk kind of quickly about active TB. And TB and HIV is very difficult to manage, and so it should be done in conjunction with both an HIV expert and a tuberculosis expert. As I mentioned, TB becomes more common and has more atypical presentations than HIV, and it's therefore more difficult to diagnose. And sometimes patients don't get diagnosed immediately and may have risk of transmitting it among their contacts. But there's also issues of the fact that HIV infected individuals are at risk for other infections and other comorbidity, which mean they can be infected with two things at once, or they can also, it may be difficult to distinguish TB versus something else. Both TB and HIV require a number of pills, so the pill burden can be difficult for patients. Drug-drug interactions are substantial, as well as the risk of side effects, overlapping toxicities, in particular, liver side effects, central nervous system side effects, neuropathy. There's also increased risk of relapse in individuals with immune deficiency after treatment. Reinfection after treatment can also occur if individuals continue to have significant immunosuppression. That's much more of a risk overseas where there's a lot of TB transmission. Drug resistance is a problem. And then social issues like substance abuse and mental health issues, these all affect adherence of both conditions, and it's important to manage these individuals to help them remain adherent to HIV care and also to tuberculosis. And also outcomes are worse. There's a 5-fold increase in mortality, so it's important to get on these individuals. Unfortunately, I don't think you can see my next slide, which shows x-rays, but I wanted to highlight again that CD4 cell count, when it's high, you can have a normal pulmonary presentation and clinical findings on the x-ray, but in advanced HIV, you have less typical findings. You can have what looks just like a pneumonia in any aspect of the lung. You can also just have adenopathy. You can have paratracheal or hilar adenopathy, and one of my slides shows paratracheal nodes in an HIV-infected individual. But you can also have individuals who have normal chest x-ray, because the infiltrates that you see on x-ray are due to the immune response and not so much the actual organisms that you're seeing. And so if you have a limited immune response, you then may not have many findings on chest x-ray. And I just wanted to point out quickly that extrapulmonary disease is much more common in HIV, and that's another reason why it might be difficult to diagnose, because their presentation may be different. I've got a picture of a patient who has tuberculosis of the tongue, of the larynx, of the spine, which is called Pott's disease. You can have just lymph nodes that are swollen, and while only 10% of HIV patients, of non-HIV patients, have extrapulmonary disease, a third of patients can have extrapulmonary disease or HIV, and another third can have both pulmonary and extrapulmonary. So again, very important to rule out pulmonary disease, the sputum and culture, regardless of whether or not the chest X-ray is normal. We diagnose TB by smear and culture and also susceptibilities. Typically, we get the sputum. We can also measure central CSF, urine, ascites, blood, and tissue. And truly, any sample can be cultured, but we can also do a rapid DNA test, the nucleic acid amplification, where we will probe and get within a very short period of time, typically hours, test that there is a presence of M. tuberculosis and active TB disease. The gene expert is used most often on a raw sputum sample. The FDA has only approved that. We actually, in Florida, will use it on any other sample. And again, that's a nucleic acid amplification test, but many labs won't do it, or they might not report it formally. They might do it behind the scenes, but you can always send samples to our lab in Florida, and we can do the gene expert. The gene expert also has the benefit of being able to detect TB or not TB, as well as the presence of rifampin resistance, which is very helpful, especially overseas, to detect drug resistance. The Hind test we use a lot in Florida also detects resistance to INH as well as rifampin, but many labs don't use that. I think it would probably be used more in the future. But even if there's no pulmonary sputums, we do again recommend that sputum culture and susceptibility is done. And just, I want to move on quickly to treatment because I know we're running out of time, but it's recommended that you collect your samples and then start treatment, having a low suspicion. So empiric treatment is recommended because, again, you can have negative tests and still active disease. If you have a clinical and radiographic findings that are suggestive TB, you want to start treatment. But it's very important to try to get a sample so that we know the susceptibilities and we can make sure we're using the right treatment. All patients need to be treated with directly observed therapy. It's provided by the health department. It's free to the patient. It's a very good service. And it's, again, important to manage patients with case management. So treatment for tuberculosis involves first-line medications, including isoniazid, rifampin, or arbutin. Those are both called rifamycin, pyrazinamide, methambutol. The treatment is the same for HIV-infected patients and HIV-negative patients. We use 4 drugs initially. We use more drugs initially to kill the larger number of organisms that are there initially. And I'm going to talk really only about drugs susceptible to TB. And we use the first 2 months, we try to use, again, the 4 drugs, and it's called RITE or IRZE. As soon as we get susceptibilities back, which is usually within 4 to 6 weeks, we'll go ahead and stop methambutol because that drug is really an insurance policy to make sure if there's any other drug resistance that we have enough drugs there to overcome it. And pyrazinamide is used for the full 2 months of the intensive or initiation phase, and then we'll continue INH and rifabutin or rifampin for the remainder of TB therapy. The remaining 4 months is considered the continuation phase. And so again, 2 months initiation phase or intensive phase, and then a 4-month continuation phase. And the intensive phase is typically 4 drugs, and the continuation phase we usually, for susceptible disease, taper down to just INH and rifampin. And I want to say that we treat daily, and daily in our world is 5 days a week. Usually we'll either allow them to give their own meds on the weekend, or we'll just give them a break on the weekends. But 5 days of daily therapy is an A2 recommendation in HIV given as DOT. It's very important that it is given daily during the full 8 weeks because we've done studies that have shown that intermittent therapy has an increased risk of acquired rifamycin resistance, and without rifampin, we would have to treat patients for up to 18 or 24 months. That's a significant problem given the potential for drug interactions and overlapping toxicities. In the continuation phase, again, it's preferred that therapy be given daily if at all possible, but because, again, of the risk of acquired drug resistance. But in some patients, we will treat 3 times a week if they're doing really well and there's a low burden of disease and the HIV is under good control. But again, that decision needs to be made in conjunction with an expert. So my next slide just shows you sites of TB disease, and I'm sorry, it looks like the slides are not coming through on my end, but maybe they are on yours. Again, most patients with HIV, just like with HIV-negative patients, are treated only for 6 months, but individuals who have positive cultures at 2 months will extend their therapy to 9 months, particularly if there's a lot of TB disease, such as a cavity. Most extrapulmonary disease can also be treated only in 6 months, but we do extend it for CNS involvement from 9 to 12 months, and we often treat those individuals with steroids. In patients with bone and joint disease, we might also extend to 9 months. So the duration is not just the number of doses, not just the calendar time. We also look at the number of doses. And again, TB experts can help you with that. I'm not going to talk about TB in children because that's something that is a whole other topic, but you have some references here. So I do want to quickly, in my last few minutes, just mention that we weigh the risks and benefits of when to start ART in patients who are not already on it. If they're diagnosed with TB and they're not yet on antiretroviral therapy, weighing the benefits of getting them started immediately on antiretroviral therapy with the risk of the potential for immune reconstitution and potential for overlapping toxicities and drug interactions. But we now have very good evidence that patients who have HIV should be getting ART at the same time as TB treatment as early as possible. There have been at least 3 randomized controlled trials, and it shows that starting therapy as early as possible is of benefit. And if patients are ART naive, the CD4 count is less than 50, we recommend that ART be started within 2 weeks. If they have higher CD4 counts, you can potentially start ART a little bit later so that they get used to the TB therapy and the risk of immune reconstitution might be a little bit lower. And there's a little bit less evidence about TB and meningitis. But briefly, when I talk about immune reconstitution, most often that refers to the paradoxical immune response that occurs when patients start to get better. They start to be on antiretroviral therapy, their immune system gets better. All of a sudden, their immune response recognizes they've got tuberculosis, and it begins to appear that the patient is getting worse. And so they can have fever, they can have enlarged lymph nodes, worsening chest X-ray, and new sites of pulmonary disease occur. And it can happen anywhere from 2 to 12 weeks after starting therapy. It can also happen in individuals who are not on TB therapy at all. It's not required that you start antiretroviral therapy unless there's a significant concern for toxicity. You can typically just treat with supportive care, antipyretics, nonsteroidals, and fluids, but we do use corticosteroids if there's CNS disease or if there's life-threatening conditions. And I have a patient case here you can take a look at when the slides come back up, basically showing an individual who had basically what appeared to be a tracheal peritracheal adenopathy. It got a lot worse, and actually presented with stridor and was unable to breathe. And so in that individual, as the immune response got worse and the nodes enlarged, that patient did require steroids, but was able to improve and get better. And then we had another, it's not uncommon for patients to develop pleural effusion or new CNS lesions. And again, anytime you have TB in the brain, steroids are indicated. And so I'm not going to go into the details because we have our lovely TB card, but TB drug interactions are significant. And you can tell on the slide here that there are no interactions between rifamycin and NRTIs or entry inhibitors, but rifampin does interact with PIs. It can be given with NRTIs, especially efavirenz, and rifabutin can be given with some of the other HIV classes. And so I would recommend that you refer to the card and also a TB expert. And this clinical portal shown here is also a really useful tool for looking at drug interactions and also making sure you can see the latest guidelines on how to manage TB and HIV. So I'm going to go ahead and close, just helping you remember that all patients with TB need to be screened for HIV. All patients with HIV need to be screened for both active disease and also latent infection. You need to manage these individuals as aggressively as possible. Be very careful managing them in combination with an expert. And we are here for you at 1-800-4TB-INFO, and we'll be delighted to take call as at any time for any kind of questions for TB disease, TB infection, drug interactions, anything at all. So at this point, I'm going to go ahead. I'm available to answer questions. I know that some of you may need to move on, so we're going to go ahead and open it up to questions for a few more minutes. Taryn?
We did receive one question in from Janie D, but she said that you had addressed her question in the presentation, but she did ask specifically about, let's see, She learned that last week for patients diagnosed with HIV and TB at the same time, it might be unwise to start both HIV and TB meds simultaneously due to the risk of the syndrome, and asking if you could talk more about that syndrome and things to consider when deciding whether to start the TB or HIV therapy first.
Yeah, absolutely, and that's a great question, and I did have to kind of rush through that a little bit, but I have some slides at the end that I didn't talk about, that they're there just for your information, but anemia reconstitution, again, is a really common problem. It's, 8 to 42% of our patients, and it's important to be aware of it because your patient may seem to be doing better, and then they can get worse, and so because if you remember I had the slide that was like a scale and we were balancing the need to get these patients with tuberculosis on antiretroviral therapy so that their HIV gets better, but also because it improves the immune system's ability to fight TB, but there is an increased risk of immune reconstitution. And so the trials have been clear that you do need to start antiretroviral therapy as early as you can, but patients also have an increased risk of side effects and of the immune reconstitution and even more other morbidity and mortality. So the guidelines say that if they're already on ART, you should go ahead and start TB treatment immediately, and you don't need to stop your ART, but you do need to make sure that you're on a regimen that does not interact with your antiretroviral therapy. And so you look at the patient drug chart that we gave you, the TB HIV card, and you try to do the best you can, either using rifampin with something that doesn't interact with rifampin or using rifabutin, and we can help with that. But again, patients with very advanced CD4 cell counts less than 50, it's recommended that ART be started within 2 weeks. There is an increased risk of IRIS, but you just can manage those individuals and have a low threshold, be on the lookout for that, and try to jump on that as quickly as possible. If they have a CD4 count above 50, you can wait a little bit longer, and it's recommended that ART be started within 8 to 12 weeks, and both of those recommendations are A1. So I hope that helps. It is a complicated thing. Sometimes it's mild, and sometimes it's more severe. And it's important when you have something that looks like the patient might be worsening or there's some new clinical finding, make sure that you're ruling out other things like new infections, drug non-adherence, or malabsorption. IRIS is a diagnosis of exclusion, and so there's not really a diagnostic test for it, but again, make sure there's no other issue, and then you can presume that it's TB IRIS if you rule everything else out and just manage them supportively. So any other questions?
We'll open it up to the floor for questions. If anybody has any, you can write them in the chat box below. I know we're running short on time, and I did want to also point out that there is a TB HIV pocket card that is hot off the press. It is located in that files pod on the lower left-hand side of the screen there, and also a PDF version of Dr. Haley's handouts from this PowerPoint presentation are located in that pod as well.
And is there a website where we keep this card? Because this card does get updated. HIV drugs come out fast and furious, and I'm sad to say they're not usually that much advances in TB. But changes do occur, and new knowledge comes out as well, and so we try to keep that pocket card updated. And I think there's a website for the most recent version. Is that correct?
There is. Both SNTC and AETC will have them on our websites. You all are the first to get it here uploaded. We've not currently updated the websites with the new pocket card, but that will happen this week.
I want to also put in a quick plug for our SNTC website. We have some awesome TB resources there with a lot of archive webinars and also tools, patient tools that can help you with screening and with diagnosis. There's a whole pediatric TB series, and you can email any of us. My email is connie.haley, Haley, at medicine.ufl.edu, and I'm happy to take calls or emails anytime to help with any kind of clinical questions related to TB alone or TB HIV. So I think I see one more call. Let's see.
Karen, I can't see that full question. Oh, here it is. So any evidence that IGRA and or I think it wants to say skin tests can become negative with successful TB therapy. And so Lewis Strackman has brought up a really good question. And so interferon gamma release assays, there is a lot of literature and a lot of interest in evaluating how these work. As I mentioned, we have 100 years or more of evidence with the skin test. And with IGRAs, it's just, much more recent, just in the last 10 or 15 years. And so a lot of clinical studies are being done. And we are finding that there are some conversions and reversions where some patients may revert to negative. And it's unclear how much of that is due to successful therapy or how long it can persist. And so we are continually studying this. And I've got some great review articles I could share if you want to email me. But, I think there's just not a good answer right now. How long the immune response can be detected and whether or not it's impacted by treatment. We also are not sure whether or not one or the other of these tests it does better at predicting who's going to progress active TB disease from infection, and those are areas of intense study right now.
Great.
I thank you all for those questions, and again, you're welcome to send more questions to us electronically later. Karen, do you see any other questions?
No, ma'am. You got the last one, and like Dr. Haley said, and you do have my email. If you do have other questions for Dr. Haley, I'm more than happy to pass those along to her as well. You should shortly receive an email in your inbox with an evaluation link for the webinar, and you can respond directly to that email. It will come to me. If you have questions, I'm happy to forward those along to Dr. Haley.
And Karen, did people see the poll down there in the corner? I would be happy. An hour is not nearly enough time to help you feel comfortable managing patients with TB and HIV, but I would be more than happy to share some clinical cases and vignettes of questions that we get often about management of these individuals with TB or latent TB infection, clinical scenarios that can be challenging, even common things that we see. So if that's something of interest and people want a part 2 where we just present mostly patient scenarios and cases, we would be more than happy to do that.
It looks overwhelmingly like people do want to see and hear more, so we can absolutely get something like that together and on our calendars.
Well, thank you for allowing me to participate in this, and really appreciate the audience. And I know it's early, and people may not have had enough coffee to ask questions, so please don't be shy. If you need anything later, we're here, 1-800-4TB-INFO. And I know that my HIV colleagues at the AETC, the Florida AETC, and North Florida AETC are also available and very willing to help with patients. And it's great that we're able to work together on all of these things.
Yes, absolutely. We appreciate you being here, Dr. Haley, and appreciate our audience for tuning in so early in the morning and for asking some great questions. So if you all don't forget, if you would like continuing education credits for this event, to check the email that you used to register for this event, and you will have a link for that that will allow you to print a certificate immediately also, but these will also be reported to CE brokers directly. So you'll have 1 week to complete that evaluation. Thank you very much, everyone.